Okay, so this is what I'm hoping to cover. So we'll just reflect a little bit about the diagnosis, the definition of joint hypermobility, a little bit about its prevalence as well. We'll present some of the evidence about the impacts of the, particularly the personal impact of joint hypermobility, and the sort of expert opinion about how joint hypermobility syndrome should be managed. A little bit about the perspectives on physiotherapy, both from a patient perspective, but also from a clinician perspective as well. I'll then talk about the systematic review that we've recently published on the effectiveness of exercise for joint hypermobility. And then I'll talk about some ongoing research that we're involved with, which is testing in a feasibility randomized controlled trial and intervention, actually, that we've developed for joint hypermobility as well. Before we start, however, I think it's probably worthwhile recognising that in many cases, joint hypermobility can be a real asset. So if we think of dancers and gymnasts and a range of sports people, musicians, etc., it actually allows them to function at quite a high level. And I think there's an important distinction to be made between joint hypermobility, which is quite prevalent, obviously, within the general population, and what we term joint hypermobility syndrome, which is where joint hypermobility, for whatever reason, starts to become a problem, and people suffer from joint pain, which then has an impact, obviously, on their physical well-being, but also on their psychological well-being as well. So a lot of authors now have started using this term generalized joint laxity to try and more adequately distinguish between the syndrome, so joint hypermobility syndrome, and just this natural bendiness that a lot of people have out there. And what I'll be concentrating on, obviously, for the vast majority of the talk is joint hypermobility syndrome, rather than just talking about joint laxity or generalized joint laxity. Okay, I quite like this definition. This was written by Bill Ferrell, who was a consultant rheumatologist over in Glasgow. And I'll just sort of pick out some of the main features here. So obviously there's something about hypermobility, okay, so joints moving more than they should do, perhaps. But there's this important idea that pain has to be associated with it to sort of clinch this diagnosis of joint hypermobility syndrome. And there's also a process of excluding other possible diagnoses as well. So the example here is rheumatoid arthritis, but there's an exclusion process of other potential pain conditions. And there are some recognised diagnostic criteria. So the Brighton criteria were developed in 1998. I think first started to be published sort of the year after that and into 2000. And this is normally the point when people start trying it out on themselves, okay? But as an integral part of the Brighton criteria is what we call the Baton criteria, or the Baton score, which is a 9-point score of how far different joints move. So basically you score 1 point if you can bend over and touch your toes, which I haven't been able to do for a very long time. It's actually if you put your hands flat onto the floor with your knees straight, so you get 1 point for that. And then you get 1 point for each limb, so left and right side, for some of the other movements. So if you can pull your thumb right down onto your forearm, if you can hyperextend your little finger by 90 degrees, if you can hyperextend your elbows by 10 degrees and hyperextend your knees by 10 degrees, then what you would pick up is a point for the left and point for the right. So that way you build up a 9-point score. So the Brighton criteria use that, and that Baton score has been in existence for quite a long time. So they've integrated that. You'll see that some of the other key features then is about joint pain. Okay, so again, we've already said that that's crucial to sort of clinching that diagnostic criteria. But there's a range of other sort of minor criteria there as well that you can see listed. And basically, you can reach a diagnosis of joint hypermobility syndrome with a mixture of major and minor criteria, so in different degrees. So that's the sort of recognized diagnostic criteria. When we try and look at the prevalence, however, of joint hypermobility syndrome, we hit all sorts of issues. When you start reading the literature in this area, it is fraught with difficulty because of different diagnostic criteria that had been used in the past, and the fact that even if people are just using the Baton score, they have used historically different cutoff points. So the Brighton criteria, for example, the major criteria is 4 out of 9, but in other studies, when you start reading, they've used 3 out of 9, they've used 5 out of 9, they've used 6 out of 9, etc. So it becomes really difficult to try and sort of pick out actually what we're dealing with. It's also really difficult sometimes when you read in the literature to find out whether, in fact, these are symptomatic people that they're talking about, or whether they're actually just people who have this generalized joint laxity. So is it just bendy people, or is it bendy people with pain? So there's some difficulties there as well. However, it is, having said all of that, recognized that generally hypermobility is more common in children, women and girls are more prevalent as well, and some ethnic groups as well. And there is a figure which is quoted. I'm always really careful again to sort of flag up that this figure is for symptomatic joint hypermobility. But one of the figures which is quoted is approximately 5% of women and 0.6% of men have symptomatic joint hypermobility. Now, we're very lucky in Bristol that we've got quite a large epidemiological database that some of you may have heard of. It's the Avon Longitudinal Study of Parents and Children, where back in the early 1990s, there were 15,000 mums to be recruited. And what has happened over the years is that this cohort has been followed up, so both the parents and the families, but also the children that were born in the early 1990s as well. And when these kids were aged almost 14, they had some Baton scores taken. So we've got a unique opportunity to be able to study what has happened in terms of their hypermobility since that time point. And they're coming up, they're not kids anymore, they're coming up to age 24 now. And you'll see that there's 6,000 left at that time point in terms of complete data that we were able to use. So there's been some attrition over the years from that original 15,000, but still large numbers. And what we looked at was just the Baton scores that they were reporting aged 14. Now, again, you remember the Brighton score, or the Brighton criteria for joint hypermobility syndrome, uses this cutoff of 4 out of 9. Now, if you look at 14-year-old kids, almost 20% of them will score 4 out of 9, which from a clinical perspective doesn't sound that useful, that discriminative in terms of trying to identify people with potential problems. So what we looked at was a range of different cutoffs. And if we used a much higher cutoff of 6 out of 9, that figure dropped to about 4%, which seems potentially more important clinically. And what we raised in this paper was the issue of, is the Baton score cutoff of 4 out of 9 useful? Should we be using something perhaps higher? But I think also what we're raising is the issue of the whole diagnostic criteria as a whole. I think there are problems with it. I don't know how you would go about trying to revise those. It would be a huge research program in its own right, but it's not perfect. Again, having said all of that, the Brighton criteria are what we have. That is what we should be using, I think, until we get something which is better. Okay, so that's a little bit about diagnosis, a little bit about prevalence as well. If we just move on to the impact, and this slide is a little bit busy, so I'll just sort of pull out some of the main things. We had a PhD student here in Edinburgh, so Francis Fatoye, who started to look at the impact of joint hypermobility syndrome on children with the condition. And he looked at a whole range of things. So you can see them listed there. So we looked at gait, so we looked at 3D motion analysis of how these kids were moving. We looked at pain, we looked at proprioception, range of motion, strength, etc. And basically what he found was that against healthy age and gender matched controls, absolutely everything that was measured was a problem for these children compared to those healthy controls. And if you take quality of life, it wasn't just the overall quality of life score, it was every single domain of quality of life. So within that was social functioning, school functioning, emotional functioning, physical functioning. Everything was impacted negatively in children with that diagnostic label of joint hypermobility syndrome. There's a group in Norwich, so Smith et al., who've published very recently actually a number of systematic reviews in this area, and proprioception is one of the things which receives a lot of attention in joint hypermobility syndrome. They looked at and did a meta-analysis of the data around proprioception, and yes, proprioception is negatively affected in joint hypermobility syndrome compared to healthy controls as well. And they also did a review of the psychological impact. And again, things like fear, agoraphobia, anxiety, depression, panic disorders, all of these things are negatively affected as well. And we've got a range of work. So we've got 2 PhDs ongoing at the moment. One is looking predominantly at the sort of physical impact, if you like, in broad terms, and we're lucky to have a health psychologist who's looking at the psychological impact of joint hypermobility syndrome in adults at the moment as well. And the other thing that we've done is, because there didn't seem to be really good measures that were sensitive to the types of problems that patients were telling us about, we've recently developed an outcome measure to try and assess that impact of joint hypermobility as well. So we've called it the Bristol Impact of Hypermobility Questionnaire. Validates really, really well against the SF-36 physical component score, and we did in our mind sort of develop it as a physical function score from the off. Again, we presented that work in Buenos Aires. You guys were there as well. Sorry we didn't meet up. And we're obviously preparing that work for sort of wider dissemination at the moment as well. So there's some good evidence out there, but there's more to be done in terms of really trying to get a handle on the impact. Again, using the ALSPAC database, we've been able to look at hypermobility aged 14, and we instigated some pain measures aged 18. So we were able to look longitudinally at the links between joint hypermobility, age 14, and what that may be associated with in terms of pain aged 18. What we found was that if you were hypermobile, and we did use that much higher cutoff point of 6 out of 9 rather than 4 out of 9, but if you were hypermobile, you were twice as likely to suffer from at least moderate pain in the shoulder, knee, and ankle or foot. If you superimposed obesity on top of that, i.e. if you were, or if these children were hypermobile and obese, that figure rose to 11 times more likely to suffer from knee pain. So there's potentially something there about obesity, as there is in the osteoarthritis literature. So the NICE guidelines for the management of osteoarthritis have right at their core, if necessary, weight loss programs. So there may be something biomechanically in terms of weight having an effect on pain in joint hypermobility syndrome as well. When we were developing the outcome measure, so our bio questionnaire, we involved the Hypermobility Syndromes Association and had a huge response rate. So 624 people filled out our new questionnaire, along with the SF-36 questionnaire as well. So we've got some really useful information from this. And if we think about the impact in terms of where people report pain, what you'll see is that the most common areas are the back, the knees, shoulders, hips, neck, etc. Okay, so over 80% of people are reporting pain in those areas. Now again, think back to the Brighton score. Yes, the back is in there. Yes, the knees are in there. But actually, in terms of a diagnostic workup, shoulders aren't there, hips aren't there, neck isn't there, feet, ankles, elbows aren't there either. So there's some important joints which aren't currently part of that diagnostic criteria that are causing problems for patients. In terms of pain intensity, they're reporting a median score of 6 out of 10, so moderate to severe pain. Fatigue, again, was mentioned earlier. Fatigue, again, we've got a group in Bristol that's doing a lot of work on rheumatoid arthritis, so fatigue and rheumatoid arthritis. And we've borrowed their fatigue scales, which looks at the severity of fatigue, the effect that that fatigue has them, and their coping with fatigue. And what we found was that patients with joint hypermobility syndrome are reporting the same severity, the same effect, the same problems with coping with fatigue as rheumatoid arthritis patients. And in terms of the SF36, 88% of respondents were below population norms for the physical component of the SF36, and a majority, so 53%, below population norms for the mental component as well. So again, more evidence for the physical impact, but also this psychological impact of joint hypermobility syndrome. We've also run some focus groups. So we've, sitting patients down, really trying to explore the impact that joint hypermobility is having on them. So we've run a number of focus groups around the country, and these are the sort of the key themes. I think in terms of the impact, there was things that we would have expected there. So a lot of people talking about the pain, talking about the fatigue, talking about proprioceptive difficulties, so dropping things, tripping, stumbling, those types of difficulties. And also this idea of repeated cycles of injury. So, and repeated cycles of injury in different joints as well. So, whereas in knee osteoarthritis, for example, it's the knee, very often in these patients, the pain moves around between lots of different joints. They were telling us about their frustration with health professionals, that they don't know about joint hypermobility, don't know how to diagnose it, don't know how to manage it, that the whole process of getting the diagnosis was very slow, very convoluted. Okay, they're back and forth. And again, this will be familiar to you with lots of other pain conditions as well. But once they got that diagnosis and got referred to somebody who did know about joint hypermobility, there was some really positive comments about how they were then managed, which was good. And again, this idea that education for health professionals, but also education for patients was really key in terms of helping patients to manage their condition. And again, it came across quite strongly that they wanted the skills to be able to manage it themselves. So they did internalize it, if you like, and see it as their condition, something that they would have to live with, if you like, in the long term. Okay, so that's some of the data about the impact. This is a really nice paper by Rosemary Keir and Jane Simmons about management of joint hypermobility. And this, I suppose, is the sort of expert sort of view about management. So this is sort of an evidence-based paper, so lots of sort of references for some of the recommendations within it, which is really nice. So they talk about the aims of treatment being about pain relief, but this idea of it's again being a long-term condition, that what you're aiming to do is to try and reduce, if you like, the recurrence of joint pain sort of over time as well. And they present a lot of evidence for effectiveness of things like education and exercise as well. And they actually split the paper down into different types of exercise, all the way from sort of posture re-education, proprioception, all the way through, I suppose, to more general physical activity and fitness as well. So that's the sort of expert view. And what we're going to move on to now is just to think about, right, well, what do patients say about physiotherapists and physiotherapy? And what do clinicians with a special interest in this area say about people with joint hypermobility and their experiences of using physiotherapy as well? Okay, again, I've sort of alluded to the focus groups that we ran before looking at the impact, we also asked those patients about their experiences of physiotherapy. So this is this data. We also interviewed clinicians around the country as well, and these were self-selecting clinicians with a special interest in joint hypermobility. Vast majority of them were physiotherapists, but we did have 2 podiatrists who took part in those focus groups as well. And again, these are the main sort of themes that came out. Again, a big sort of message really that was coming out was the importance of education and training for health professionals. Okay, so that was really quite strong. There was, again, a frustration on behalf of the patients that often when they were referred for physiotherapy, they were referred by their GP or whoever the referring person was for single joint pain. So, for example, they may have gone to their GP and this week it happened to be their knee that was painful and they were referred for physiotherapy for knee pain. And, of course, by the time they get to their physiotherapist, it's not in their knee anymore, it's somewhere else. And there seemed to be an inability of physiotherapy services or perhaps individual therapists to sort of deal with the whole body rather than deal with that specific joint. So that may be a service issue, it may be an individual therapist issue. So there was this call, if you like, for a much better whole body approach, and I know I'm preaching to the converted in an audience like this. Also this idea that physiotherapy needed to follow a much more long-term condition model of service delivery rather than treating just acute injury, acute pain. And interestingly, again, from patients and from therapists was this call for, we need more research, we need more information and understanding about these patients so that we know how to better manage ourselves as patients, but also from the therapist perspective, better knowledge to be able to sort of work with and help patients as well. We've just had a paper accepted for publication in Musculoskeletal Care, which was a UK-wide survey of physiotherapists and how they diagnose, how they assess, how they manage joint hypermobility as well. I think what was striking from this was that not an awful lot of people had that training. Okay, so training is a thing which will come up on most of my slides, I think. So only about 30% of patients had any sort of training in managing joint hypermobility. The Brighton criteria, so even though they've been around for quite a while, weren't used that often either, so only about 30% of physiotherapists using those. What was really encouraging, however, was that when we asked physios about the aims of treatment and the sort of interventions that they used in treatment, there seemed to be a really good match there, that there seemed to be a lot of clarity about what they were trying to achieve and how they then went about doing that. So there was a focus on, again, things that you would hope to see in long-term condition management, so advice, education, exercise, self-management approaches, okay, were quite prevalent within there. However, interestingly, pain relief was not very high up that list of aims. Now, maybe all sorts of reasons for that. Maybe some of the other things that they were saying were aims, they were hoping that they would get pain relief as a byproduct of that. But pain relief, I can't remember offhand, but I think it was about 14th or something in the list, so not high up in terms of priorities at all. However, when it came to assessment, so what we asked them specifically about what sorts of outcome measures they were using, pain was the first thing that they were measuring. And again, there might be all sorts of reasons for that. Okay, pain scale, very quick and easy to do in clinic. It's what you learn as an undergraduate physiotherapist perhaps as well. But there was a bit of a mismatch in that, okay? So that what they were trying to achieve and what they were then judging the success of their therapy on was not really aligned. We also got some information about what an average service might look like. Again, this might be a bad service, it might be a good service, we don't know, we can't make a judgment about the effectiveness of the service, but an average service was an initial assessment of at least 40 minutes, Follow-up assessments or follow-up treatments that were 30 minutes or less, 6 sessions or less, and 4 months or less in terms of duration of treatment. Okay, so that came across as a pattern quite strongly. And again, thinking about this idea of acute model versus chronic model, we asked about things like maintenance reviews, and there was a bit of a split actually. So some services, some therapists are able to offer a maintenance review, so about 30% reported that they always or frequently offered a maintenance review. However, a sizable proportion, so 39%, rarely or never offered that. And there are other surveys, okay, so a much larger survey actually than ours. It was just been presented a couple of weeks ago at Physiotherapy UK Congress. And yeah, I mean, very similar sort of findings and conclusions from ours. Interestingly, they found a positive link between training and improvements in confidence in terms of assessing and managing, which you would hope would be the case, that if you train somebody up, that they're then more confident in those things. And also a sort of similar survey published last year on treating children with joint hypermobility as well. Again, very similar findings. And again, the sort of last bullet point there, information about education and management, again, sort of came up as an important theme. Okay. And now I just quickly want to give the results of a systematic review, and I'm presuming this is why I was invited to talk, probably, because we've just recently published this. So what we wanted to look at was the literature that was out there, and we knew that there wasn't that much literature out there, okay, but we wanted to try and look at it in a systematic way to see what there was there in terms of guiding us on the effectiveness of exercise. But because we didn't know there was much, or we knew that there wasn't much there, we weren't very prescriptive in the review about specific types of exercise, clinical outcomes, or even study designs. Okay, we wanted to gather in as much information as possible. However, the studies that were included, we then had a very rigorous process of assessing the quality of those studies. So we used the CASP tools and obviously used the appropriate checklist for the study designs that we included. And what we ended up with was just 4 studies that have assessed the effectiveness of exercise in joint hypermobility. Now, again, I'll just sort of pick out some of the key features of some of these. The first thing to note is that only 2 of them are randomized trials. Okay, so only 2 of the 4. The other 2 were just cohort studies. You'll also see that there's a mixture of child studies. So there's 1 study in children, 3 in adults, relatively small participant numbers, so between 20 and 57. And even that N equals 57, there was quite large dropout. So I think there was something like a 44% dropout. So what was left at the end of the study was quite small numbers as well. The Kemp et al. Wasn't a control study, it's what we call a comparative trial. So it was comparing 2 different types of exercise. So it was looking at generalized exercise versus joint-specific exercise. So there wasn't a control group as such within that. So in terms of your gold standard design, if you like, there was only 1 in there. So the randomized control trial by Sahin et al., which did have a no treatment control group. In terms of the exercise interventions, again, I'll just sort of pull out some of the main features here. The first thing is brief intervention, so between 6 and 8 weeks of an intervention. A real difference in terms of the levels of supervision and where the exercise was being conducted. So a mixture of home exercises versus home plus clinic supervised exercises, or in the case of Sahin et al., clinic exercises. And you'll see 3 times a week for 8 weeks supervised by a doctor. Okay, so there's something there, I think, in terms of the generalizability and the feasibility of conducting something like that, certainly within the NHS, but most other healthcare services as well. And there's something about the types of exercises and the joints as well. So some of them are very specific to the knee joint. So again, this is a whole body problem, okay? So information specific to the knee may not be that generalizable. And some of the exercises very specific to proprioception, whereas some of the other exercise programs are a bit wider, okay? So you'll see general fitness and sort of whole body type approaches as well. So a real mix in terms of what's being looked at. The results, however, when you actually look at those, so if you just think about changes in these patients over time, it all seems quite positive actually, that if you give somebody exercise, they do seem to get better in a range of outcomes. So whether they're patient-reported or parent-reported in terms of the child study, whether they're objective measures of things like proprioception or strength, etc., there seems to be good evidence that patients get better over time. However, of course, we don't have that really good control situation and know whether those effects are specific to the exercise. And if we look at things like standardized effect size for pain, so about 0.3 of an effect size is something that patients might consider useful or clinically relevant. You'll see the effect sizes are actually quite large. So anywhere between 0.75 and 1.7 would be considered quite large effect sizes. So patients do seem to get better over time. Interestingly, there was no adverse effects reported. Whether there were adverse effects or not, of course, is something different, but certainly within the studies, they weren't reported. There was no difference in the effectiveness, so that you're looking at the Kemp study, of the two different forms of exercise. So they were both equally effective. And what was really interesting about the Sahin study was that they based their conclusion of exercise being useful on the basis that people in the exercise group got better and people in the control group didn't get better. However, what they didn't do, which makes me a little bit suspicious, I need to be careful with my choice of words, but they did not do a direct statistical comparison of the control group and the intervention group at the end of treatment. Okay, which I think was a bit of a miss by the editors and the sort of peer review process as well. But that's a real shame that wasn't done and we don't have that information. But because of that, we're still left in a situation where we don't have clear information about cause-effect relationships. So we suspect from this that exercise might be effective, but we don't have those clear effect relationships as yet. And I've already mentioned some of the methodological issues, and yeah, I don't think we need to go into those, but like any review, final conclusion is more robust studies required. Okay, and again, this is borne out in other literature. So again, the group in Norwich have published a review which was slightly wider than ours, so they included occupational therapy interventions as well, which I think was only one study which looked at splinting. But again, suggestions of efficacy, but this lack of control and problems with sample size, etc. And a really interesting, again from the same group, this isn't a review, it's a qualitative study of families and children and young people who were undergoing exercise intervention. And they were particularly interested in adherence. So I think contextually this is important for us perhaps when we're designing interventions. So again, from the transcripts, there was this suggestion that exercise was beneficial. So again, adding a little bit more information to that debate. But in terms of the things that improved adherence was where you had highly motivated parents, okay, as you might expect, where the family sort of adapted their routines to try and integrate exercise into their sort of day-to-day life, where they exercised as a family, so it wasn't just the child or young person doing exercise alone. That was seen as important. and obviously where they saw benefit. So if they were seeing benefit, they were more likely to adhere and continue with the exercise program as well. And non-adherence, okay, you can read for yourself, but are more or less the flip side of the factors that improved adherence. So as I say, maybe some things to think about when we're designing interventions. Okay, just very quickly then, so the last couple of slides is just to introduce a randomized controlled feasibility study that we're conducting at the moment. So what we've taken is all of the information that I've just talked about. We worked then very closely with experts in the area in terms of expert clinicians and also patients to develop a physiotherapy intervention package. And we were very careful to try and get something that would be implementable, we thought, across the NHS. So we've even taken into consideration, again, good or bad, what is actually being delivered out there. So the number of sessions, how long those sessions last for, etc. Okay, so I'll just talk a little bit about that. So we've called it the Physiotherapy for Hypermobility Trial, or the PHYT trial. So this work is funded by the NIHR, so the National Institute of Health Research, the Health Technology Assessment Programme. And they tasked us with, or we tasked ourselves with, developing and testing a comprehensive physiotherapy intervention for adults with joint hypermobility syndrome. The way that we've designed it is that what we've ended up with is an advice-only group. So they get a one-to-one detailed advice session, which is then supplemented by booklets from the Hypermobility Syndrome Association and the Arthritis Research UK booklet as well. So that's the advice session, so everybody gets that. And then everybody is randomized to either just have that or also have a 6-session physiotherapy intervention. So that's the basic design. Because it's a randomized controlled feasibility study, our primary focus is on the feasibility issues. So it's, can we get people into the trial? Can we randomize them? How acceptable is the intervention? We're looking at a value of information analysis, looking at economic data to see whether indeed it is going to be useful to move on to a larger trial in the future. But probably the most important thing are the interviews. So we're talking to all of the patients, we're talking to the physiotherapists who are delivering the intervention and trying to get as much information about how we need to change it, tweak it for any future randomized controlled trial as well. And then we've got a range of secondary outcomes in there. The stage that we're at the moment is that we've completed recruitment and we're just going through now finishing the treatment and study follow-up. And obviously the plan is to develop a full multi-centre randomised controlled trial in due course. And I'm a little bit careful about how much we share about the intervention itself because it might be rubbish. So, but this is broadly what it is, okay? So we've got 6 30-minute sessions over a 4-month period. So because it's a randomized trial, we need some sort of boundaries on it. Otherwise, we can't have a study which is going on forever. So we've gone with that 4 months, and we've kept it as a one-to-one intervention. Now, what we didn't do was start from scratch. We've already got, we've got a colleague in Bristol who's worked with Mike Hurley across in London, and they developed the ESCAPE programme, which is for osteoarthritis pain. And what we've done is effectively to adapt that for joint hypermobility. So it's got proven clinical effectiveness, proven cost effectiveness. It's been adopted by QIP, etc. So we've adapted that for the purposes of joint hypermobility, added in things that patients said that they wanted that were really specific to joint hypermobility, took out some things that were relevant, obviously, to osteoarthritis that were less relevant for hypermobility. And there's all sorts of tools. So there's a handbook that goes along with it, all sorts of tools to aid sort of reflection on discussions and learning that they're having about their condition. There's action planning tools in there as well. And these are just some of the key sort of components of the types of things that are covered within it. And pardon the pun, but there's a lot of flexibility in the intervention package to allow the physiotherapist to tailor the information and tailor what is focused upon to the individual patient. So the things that are up there, if they're clearly not a major issue for the patient, then they don't have to be covered, and they can also move around in terms of the intervention about what is covered first, etc. So a lot of flexibility in there. So in conclusion then, I think I've gone over by 1 minute, I think. In conclusion, I think what I've tried to present anyway is that we're gathering quite a lot of data. There is data there to suggest that there is a negative impact on physical and psychological well-being, that patients are telling us that the process of getting a diagnosis and the management through that difficult period of getting a diagnosis is often suboptimal. However, very often they are happy once they meet a specialist who does have some interest in joint hypermobility. Health professional education does seem to be key, and that's coming out not just from our group but from some of the other groups as well. It does need this long-term condition management approach, so again moving away from treating the knee pain to looking at joint hypermobility syndrome as a sort of long-term sort of whole body condition. And exercise is likely to be effective, but we still need that better research, and obviously we're trying to do that at the moment. There's also other groups in the Netherlands and Belgium at the moment who are running trials of exercise as well. So it's going to be interesting to see what comes out of all of that work. Okay, just quickly acknowledge, it's amazing how many people you end up working with over the years, but some of the co-researchers on some of the work. Our patient research partners have been absolutely integral to all of this as well, as has the patient associations. The Hypermobility Syndromes Association have been fantastic in terms of helping us with recruitment and other advice as well, and obviously our funders for some of this work as well. Okay, thank you.